but I'll tell you that. If you ask any rheumatologist, what's the difference between writers and, can you hear me by the way at the back? Is it clear? Writers or reactive, they will tell it's the same. So the old terminology was writers. Now they are saying it is a reactive arthritis. So just make the life easy. There are a lot of changes in medical terminology. For the past probably 10 years, they keep changing. Can someone tell me that a syndrome or a disease that the name has been changed? Thank you. What's the new name? Thank you. That's really excellent example. Wigner's granulomatous has been changed to granulomatous with polyangiitis, GPA. Another example. Okay. Okay, that's good. Another good example from your colleague. What else?
STDs.
Huh?
STDs.
STDs. What is it now?
STIs.
STIs. Okay. We have 3 already. One more. I need 2 more.
Mental retardation.
Huh?
Mental retardation.
Okay, mental retardation, what do they call it now?
Intellectual disability.
Okay. Intellectual disability, that's fine. What about infections? Do you know PCP? PCP in HIV patients, they get pneumocystic cariniae pneumonia. PCP. Pneumocystic cariniae pneumonia. They changed the name 10 years ago, but everyone is sticking to the old name, including myself. I can't remember the new name because it's really difficult. They call it pneumocystic Jordici pneumonia, PGP. But for me, it's much easier to say PCP, but everyone is going to understand what it is. The other one is, one more thing. We'll discuss it actually today in our lecture.
SLE?
The SLE didn't change. SLE didn't change. Scleroderma, they say now it is systemic sclerosis, but more or less they are interchangeable terminology. So there are more actually we are going to discuss. But keep in mind that sometimes medical technology, for a reason or another, if there is any meeting, international meeting, they change the name for a purpose. But for example, Wigner granulomatous, I like this name. Because really it's always, there is an image in my mind when you say Wigner. What you say, granulomatous with polyangiitis, I thought, what is this syndrome? What the definition, they are international. Make sure that when you communicate with others, they understand what is the disease. It doesn't matter what is the end, but make sure, or in the exam sometimes they give you one terminology, remember it, what's the other one, okay? And to be fair, actually, they have to give you the 2 names in the exam. Okay, it's not working. No problem. Can we see? Okay. Right. Now we have another 20 topics to cover today. Are you ready? Not 5, not 6. Okay, now kidding. 20 topics we cannot cover in 2 hours. Okay, so we have now a journey in the next couple of hours to discuss 2 things. When I get the objective, I was really confused. What is the first one?
Myasthenia gravis.
No, I am not a neurologist. You don't know the objective? Okay, I recommend for all the students when they have like a lecture, they know what is going to be discussed tomorrow. Okay? Just take like 15 minutes, 20 minutes, 30 minutes, go and review what's the topic today, what you are going to discuss. I'm not saying go and read it completely, but have an idea about it.
Fibromyalgia.
No. Fibromyalgia is actually December.
Autoimmune diseases. Connective tissue diseases.
Yes, one is connective tissue diseases, and the other one? And?
Neuromuscular.
No. Myopathies. So we'll cover connective tissue diseases and we'll cover myopathy. If you say connective tissue disease, what is it? What is connective tissue disease? What is connective tissue? Anyone know? Hmm? Connective tissue. What is it? Huh? Collagen, okay. So collagen, so connective, okay. Histology, guys. Go back to the, is it second year or what? Second year of pre-medical school. Huh? Okay. Connective tissue. So you are connecting between the tissues. So do you know how to connect between tissues? Huh? Do you need wires or copper or you need aluminum or something? You need to, of course, you need collagen and you need elastin and many other fibers that connect between the bone, between the skin, between the cartilage, between ligaments, okay? So when we say connective tissue diseases or disorders, it is actually a spectrum. It's not one disease, they call it disorders. So it's a spectrum of diseases, okay? Can someone name for me connective tissue disease?
Osteogenesis imperfecta.
Lupus, because it's affecting the skin, affecting the joints, the bones, the muscles like this. What else?
Osteogenesis imperfecta.
Osteogenesis imperfecta, it's localized to the eye.
EBS.
What is it?
EBS.
EBS.
Ehlers-Danlos syndrome.
Ehlers-Danlos syndrome. Ehlers-Danlos syndrome, elasticity. Okay. But usually it affects multiple things, not just one, okay? Not just the elasticity. What else? Marfan. Is it connective tissue disease?
Yes.
Is there inflammation in Marfan? There must be some sort of inflammation.
No.
What about myositis? What about myopathies? What about rheumatoid? What about scleroderma? So it is a spectrum of disease. Any of these diseases that will affect the joints, the muscles, the tendons, the ligaments, the bones, all together connecting, this is what we call connective tissue diseases. And there is something called even mixed connective tissue disease, which is really a unique disease by itself. Okay, so we know now that connective tissue disease is a spectrum of disorders. It's not one, not two, characterized by inflammation and involvement of the connecting tissues. And the best example is lupus. Second best example is scleroderma, rheumatoid, and so on. طيب. Can someone tell me about if you see a patient who have skin rash in the face, usually a female, come to you with joint pain, some sort of rash, hair loss, and oral ulcerations. What's this? Lupus, systemic lupus erythematosus. So usually female more than male. Do you know any percentage?
1 to 10.
Exactly, so 10 to 1, almost. Some books they said even less, like 9 or 8. But say, remember this number, around 10 to 1, usually females. They present with rash, okay, usually in the face, or they have it through eyes. What else?
Fever, weight loss,
Weight loss, ulcerations, mainly in the mouth.
anemia.
And ulceration in the mouth, it can be in the buccal mucosa, it can be in the heart palate. Is it painful or painless? Painless. So painless ulceration. They get alopecia. Okay? They get what? Photosensitivity. What is photosensitivity? So exposure to the light, especially the sun, when you go outside, they get a rash. So this is photosensitivity. And in addition to that, they will get a joint pain. They get serositis. What is serositis? Cirrhosis. Where is the cirrhosis located? Pericardium, pleura, peritoneum. Okay? And any other organs. You know, even the esophagus, does it have cirrhosis? No, it has adventitia. But other organs like the gut, small bowel, colon, stomach, it has a cirrhosis. So inflammation of the layers in the either pleura, the cardia, and the gut. They get pain, get collection, sometimes they get ascites, they get pleural fluid collection, they get pericardial fluid, so serositis. Keep in mind lupus is a systemic disease. It's not really affecting just the joint and the skin. It can affect the CNS, the heart, the gut, the kidney, the joints, psychological, everything. Is it common or not common?
Yes.
It is common.
Here?
It is here. It is common. It's one of the most common diseases in Saudi Arabia, actually, is lupus, including presentation, especially with lupus nephritis, with lupus cerebritis, with myocarditis, and so on. So remember, lupus is a quite common disease, and the problem is the challenge in diagnosing lupus. Patient doesn't come to you, they tell you that I have a skin rash, doctor, I have joint pain, I have pleurisy, I have this and that. So, I know, this is lupus. Dr. Sahibani told us in lecture, if you have these 4 or 5 features, it's a lupus. Patient doesn't present like this. They don't come to you like classical Davidson or Kumar textbook. They come to you with really a variety of symptoms and signs. And they might not come today all the 5 or 6 features. You might have one, and down the road you have another one, and the labs may be negative now, and we'll discuss that with regard to labs, and later on we'll be positive. So keep in mind that the presentation really, it is different from one patient to another patient. Now, the most difficult question for you guys is, what is the cause of lupus? Genetic, environmental,
Autoimmune.
it's an autoimmune, of course. We agree that it's an autoimmune disease. And we named last week good number of autoimmune diseases. You mentioned them already. And I said the only autoimmune that we know the trigger is celiac disease, but all the others like rheumatoid, SLE, we don't know that. Wegener's, we don't know that. Most of it is some sort of combination of things. Environmental, genetic, and immune dysregulation. They call it like some sort of activity of the, like IBD. What's the cause of Crohn's disease? What's the cause of autoimmune hepatitis? We don't know. If we know already the trigger, we can stop it, we can treat it, we can prevent it. But most of the time what happened is already came from either diet, with viral infection, they got hit and run, and activate your immune system. Unfortunately, this immune system start to attack special organs, thinking that these organs are abnormal and can be targeted to the liver, causing autoimmune hepatitis, to the bowel, causing inflammatory bowel disease, to the joint, causing rheumatoid, or to the multiple organs like lupus. So the answer for this is not really clearly known, the etiology for systemic lupus erythematosus. But it's a combination of genetics, immune dysregulation, and environment. What happened over the past 20, 30, 40 years? Why do you think that the incidence is increasing with autoimmune disease? Exactly. So autoimmune diseases like IBD, we know that the number is really increasing. And as your colleague mentioned, the reason for that, number one, including celiac disease. We diagnose now celiac disease every maybe second week or third week, I go to one case. In the past, you might see one every 6 months. Why? Because you mentioned correctly that the diagnosis now is easy, sensitivity of the antibodies is much better, availability of the tests are available anywhere, any labs, go to any private lab and find it there. In addition to that, we are exposed to some sort of toxins. Name one toxin.
Pesticides.
Hmm?
UV light.
What's it? Huh? Okay. Okay, the light, okay, from the sun, okay, what else? Cigarettes, what else? Medications? What about the food? Mac. Kentucky, you bake, you think they play a role? They play. Believe it or not. In India, for example, if you go to India, for example, IBD, for example, it's not known like in the past 20 years, you don't see cases of IBD. If you go to Africa, you don't see cases of Crohn's. But now they are seeing more and more. Because again, fast food, they are linking it. Is it really the oil? Is it the material itself? Is it because of lack of some sort of vitamins, important ones that we are not really consuming it, like a regular healthy diet? But again, most likely there is a link with the food that we are eating. Going back to the lupus. So now that the presentation is really not always classical, comes to you with all the features. It sometimes comes like episodic. Remission and relapsing. Patient will be feeling better today, and after a week or two, they relapse. They get symptoms, the joint, the rash, the ulcers in the mouth, the alopecia. So they call it relapsing and remitting. It's continuous by itself. Or sometimes with the treatment. And this is your hope when you treat the patient, he or she will be in remission. So it's relapsing, remitting, and no etiology. It's a chronic disease. It's not a UTI or C. difficile that you treat for a week or two and that's it. It's a chronic disease like IBD, like rheumatoid, that you need to have a good relationship with the patient. Why?
Compliant.
Huh?
Compliant.
Compliance to the treatment, that's good. You have to have always a clear plan for the patient, clear diagnosis. You give the patient a clear message that the diagnosis is lupus, for example. And you have to be on this treatment for a long time, maybe it is for life. It's not an infection, it's autoimmune, it's inflammation, and is there a cure? Unfortunately, we don't have a cure. Can you get cured from gastroenteritis? Yes. Can you get cured from pneumonia? Yes. You treat with antimicrobials for a few days, and خلاص, the infection is over. But these inflammations, still the immune system is there. Unless you readjust the immune system, which is not yet really in the available hands to do it. We don't have medication that teach the immune system, please don't attack the joints, don't attack the ligaments, don't attack the liver or the bowel or the serosa. We don't have this medication. What we need is just to suppress the immune system so the attack will be milder and the patient can function. Okay, so we talk about lupus and the presentation. As we told you, it is more in females, usually the age between we see sometimes 14-year-olds, yes, sometimes we see 30. Usually they are young. We don't see it at the age of 60s or 90s, or usually young female. Presenting with multiple complaints, fatigue, fever, joint pain, skin rash, alopecia, what else? Weight loss, they lose weight. They don't come to you that I'm anemic, but again, I agree with you, you might find anemia on those patients.
Joints pain.
Nephritis, so you might have what you call it, the patient will not come to you, I have nephritis, doctor. Nephritis is inflammation, not pyelonephritis, not UTI. So inflammation of the kidney. How's the inflammation of the kidney will show to the patient? Huh? Pain in the kidney, yes, in the flank. What else?
Frequent urination.
No, this is UTI, urine infection. Yes. You might see what? Blood. You would see blood. You might see what? Frothy urine. The urine becoming frothy. Why? Because of the protein. The protein, a lot of protein, they call proteinuria. The urine becomes frothy. So when the patient pees, they see a lot of froth. This is really abnormal. First time to see this. Or blood. So this is lupus nephritis. Think about it. طيب. What about the seizures?
Seizure.
Seizures, exactly. So patient comes in with seizure.
Cerebritis.
Cerebritis, the patient will not come to you, doctor, I have cerebritis. So they will come to you with symptoms. Like your colleague mentioned, seizures, that's fine. What else?
Headache.
Huh? Headache, common thing, yes.
Forgetting a lot.
Hmm?
He forgets a lot of information.
Forgetfulness,
Psychosis.
it can be psychosis. This is very, very important. Psychosis. I remember a patient who had, long time ago actually, she came from the north. She was a female. I remember her, obese, for ERCD, for CBD stone, common bladder stone. Healthy otherwise, we accepted her because ERCD machine is out of order in that hospital, so we accepted her. So when I talked to her to take a consent and explain the ERCB to her, she was really abnormal, talking to me with her sister was fine. But then she has started asking questions that I said, okay, let me just pass it, I will sign. Then I left. Post ERCB, she developed a fever, some sort of like pancreatitis, which can happen after ERCB. Then she became psychotic overnight. Became psychotic. And we thought from that, pancreatitis and the sepsis and the sickness after ERCB and the removal of stone, then next day still psychotic. First time for me to see a patient at ERCB to change to psychosis, start to shout, I don't know what she's doing in the ward, the nurses. Then the on-call resident, next day, talked to me, said, doctor, she's abnormal. I said, okay, go psychiatrist, see her. Psychiatrist actually came and assessed and they said, well, acute psychosis. Then she developed, while she's in the hospital, despite heparin, she developed deep vein thrombosis. Then we looked at her platelets, dropped dramatically from like normal to very low. Start to show manifestations within the hospital. Spiking fever, psychosis, start to have joint pain, anemic, platelets dropped. One of the smart residents, because I've been away from I'm just doing a GI for some time in hematology and intervention, said, I think she has a syndrome. She said, what is it? I think she has maybe lupus. She has something. So you're right, let's think, and it's a multi-systemic disease. If we misdiagnose it, we'll not be able to reach it. Consult our colleague from hematology, and actually from the first visit, they said it's most likely lupus. And they requested the lab. What's the lab you think that they requested? Anti-nuclear antibody, ANA. What else? Anti-double strand antibody. What else? Anti-Smith antibodies. Okay, they have a lupus panel. They request all of these, and they are actually came to be positive. Strongly positive. Strongly positive. So they managed her. They requested MRI brain. Why? Because of psychosis, they thought of lupus nephritis, and it was positive. It was inflammation of the blood vessels. And again, we go back to the connective tissue diseases. Even the blood vessel can get inflamed. So vasculitis is part of the connective tissue disease. Vasculitis, inflammation of the small blood vessels, or even large blood vessels. So diagnosed, and she was really managed with strong immunosuppression. And she improved actually. And now I start from GI, she's followed with rheumatology, and I hope she's doing well. So that's, remember the presentation, you bring a patient without history and you diagnose her with something else in the hospital. Okay? So that was a story that I remember it a few years ago for a patient with diagnosis of lupus. So we mentioned about the CNS and it affect functionality, which is psychosis, or organic seizures, for example. We go down to, say, the heart. Does it affect the heart? Definitely affect any layers. And remember, the endocardium, myocardium, and pericardium layers can affect it, can cause endocarditis, myocarditis, and pericarditis with pericardial effusion, and tamponade, and chronic pericarditis. We go to the lung. It's one of the most important really organ that will be affected by lupus. Can cause interstitial lung disease, fibrosis. And the most common one is pleurisy or sinusitis, so collection of pleural fluid in the pleural space with pain. I believe now it's functioning, so we can move now to the slides. Okay, we'll move down from the lung to the gut, and I'm gastropathologist. It's one of the most common actual organs in the GI tract. Can someone name things affected by lupus?
Pancreas.
Huh? Lupus affecting the gut?
Colon.
It can affect many things. In the GI, it can cause esophagitis, it can cause hepatitis, it can cause pancreatitis, it can cause sinusitis, it can cause ascites. And there is association with other autoimmune diseases like celiac, like autoimmune hepatitis, and inflammatory bowel diseases. So there are always autoimmune diseases that are not separate. Cannot say one, well, I am just autoimmune, don't come to me. They can combine. Like, for example, celiac disease can combine with IBD, celiac disease with lupus, and so on. So, so let's go to the slides now. So these are the objectives, we'll go through them quickly. And we already discussed the change in the names. So I'll keep it to the slide in the PDF format in the desktop. And we mentioned the definition of the connective tissue diseases and the examples of it. And again, you can see how they are combined and they are connected to each other. So in the center, you can see what we call mixed connective that will take one part from each disease, okay? So what causes, again, we discussed about an autoimmune disease of unknown etiology. It's chronic multisystemic disease that can affect any part of your body, okay? We talked about SLE and chronic inflammatory disease for unknown cause that can affect any organs. We see a good number of antibodies. One of them, as you mentioned correctly, is the ANA, anti-smooth, anti-Smith, and anti-Debristan. And more in women, and most common pattern is the mix of the like MSK, hematological, as you mentioned, anemia, thrombocytopenia, and serological involvement. You can see here the most common one is actually the fatigue, fever, weight loss, arthritis, and skin manifestation, renal manifestation. At presentation, between 16 to 36, but down the road they might get more and more percentage. But at any time you can see, for example, renal up to 73%. At time diagnosis, around 1/3 of them, but later on, probably 2/3 of them they will have renal disease. Again, GI, pulmonary, cardiac, lymph nodes, splenomegaly. You do need to remember these numbers really. It's very hard for you guys to remember what's the percentage at the presentation, but remember at least the first 4 or 5, the common things, common especially upon presentation. But the most important message for you is remember lupus can develop at any time. The symptoms can develop, the signs can develop, the disease, the organ. They don't come always at the same time. We have the SLIC classification for SLE, the clinical criteria, and immunological criteria. So you need more than 4, at least 1 clinical and 1 lab. Again, the criteria, there are many criteria. There is the American College of Rheumatology criteria, the SLIC. Remember at least one of them, what's the criteria you need for lupus? So there's a clinical and laboratory diagnosis. One of the most important presentation is arthritis, okay? And you remember last week we discussed about rheumatoid. It looks like rheumatoid in a specific pattern, but also it's different. Why it is different? It is migratory, but it's typical. Remember, migratory, rheumatoid is not migratory. Rheumatoid patient will have it will be chronic hand pain, for example. But it's like rheumatoid, it's usually symmetrical, polyarticular, can affect the knees, wrists, PIP joint. There will be short, early morning stiffness, non-erosive. So if you look at the x-rays, there will be no erosions like rheumatoid, and what you call reducible deformities or Jacob arthritis. Number 2 is the skin manifestation, and one of the most really important manifestation of lupus is the skin manifestation. It can be specific to lupus, like malarash, photosensitivity, diffuse erythema, or sometimes subcutaneous or chronic. Or it can be non-specific, and you can name it telangiectasia, vasculitis, Raynaud's, libido reticularis, which are particular skin manifestation can be seen in any other connective tissue disease like scleroderma and others. I think you know this is a butterfly rash. It can be seen in probably 50%, always in both sides of the face, and spare the nasolabial. You can see the nasolabial fold here. It is not affected and doesn't lead to any scar. Okay? This is photosensitivity, because remember that any area that's exposed to the sun will have rash. Okay? And it will resolve. Okay, after the patient disappears from the sunlight. Raynaud's, what's Raynaud's? Vasospasm, exactly. It will be pale, it will be whitish, then it will be bluish, then it will be red. White, blue, then red. Okay, white because of the spasm, then it becomes cyanotic, then will be vasodilatation to leading to the erythema. Can be seen in which condition, this one? Can be seen? Can be seen in systemic sclerosis. Vasculitis by itself is really a big topic. Can be large joint, can be medium, can be small, and lupus can affect the blood vessels anywhere in the body. And the CNS, in the joints, in the skin, in the muscles. So the small blood vessels, unless you take a biopsy, you will not be able to identify the vasculitis. So vasculitis, basically, it is not a clinical diagnosis. You can see sometimes by radiology manifestation, like CNS, cerebritis, they might see inflammation by MRI or MRA, but most of the time, they're only by tissue. You can identify the vasculitis. This is a blood vessel that has a clot, okay? And remember, most of the patients with connective tissue disease, they are prone to develop clotting, especially if they have what's called antiphospholipid syndrome. They can develop thrombocytopenia, leukopenia, anemia, okay? In lupus, they can get pancytopenia. All the three lineages will be affected, okay? Kidney involvement, this is one of the most actually important manifestation of lupus, and we do see a lot of lupus nephritis. It has classifications, class 1, class 2, class 3, class 4, based on the biopsy. And most of the patients, they present to you with hematuria, with proteinuria, they get a kidney biopsy. Sometimes you diagnose lupus based on the kidney biopsy. They don't present with skin rash or joint pain. They present with hematuria. Then you look at the blood. There is a leukopenia. There is thrombocytopenia. Then you ask about the patient about fatigue. Yes. Then the kidney biopsy will help you to reach diagnosis. Is that clear? And it's a significant cause of mortality and morbidity. Patients who require kidney transplantation. If you don't detect early and treat aggressively at the beginning, you have a window period. If the patient disappears from you, unfortunately, the patient will come to you with end-stage renal disease requiring hemodialysis. We talked about gastrointestinal manifestation. It can affect any part of the gut, from the esophagus to the colon, including the pancreas, including the liver. And one of the most important features that they call as rheumatology is when the patient presents with acute abdomen. Lupus, coming to the with acute abdomen. We should think about pancreatitis or vasculitis, like mesenteric vasculitis or ischemia. Because the inflammation will reduce the blood flow in the arteries and cause peritonitis that will lead to fluid collection. CNS, like our patient I presented before, can present with psychosis, can present with seizures, delirium, headache, and peripheral neuropathy. And psychosis can be due to the lupus or the steroid, because remember, one of the most important treatments that we are giving out to our patients is the steroids. It can be a side effect of the corticosteroids. Others like anxiety, depression, and mania. We talked about CBC and we talked about pancytopenia, pulmonary involvement, cardiac involvement, we discussed that already. Okay? So it's multi-systemic. Name any organ. I cannot say it's never been affected, it can be affected by this. There's one thing about neonatal lupus. Neonatal, that the female will transmit antibodies, which is the Rho and the La, anti-Rho, anti-La, or SSA, SSP, can cause neonatal heart block. So when this antibody transfer, you cannot unfortunately block them, you cannot stop them. But these antibodies, if they are present in the female patient, can lead to the heart block in the baby. So if you suspect lupus, screen your patient by applying the SLIC criteria and work up and refer to rheumatologist. Okay? And you can see any organ can be affected. Presentation will be different from one patient to another. Now the autoantibodies, you mentioned them correctly, but remember there are more than this antibody. We have, for example, anti-RMB, we have anti-SSA, which is for congenital lupus. We have antiphospholipid. Which one is the most specific, you think? Double strand, okay, specificity, and Smith, correct. Okay, so these are the two, Smith and double strand. What about ANA? It is sensitive, so, yeah, but not specific, because many disorders, including name, like 100 causes can lead to positive ANA. Okay? And it depends on the titer. So ANA can be 1 in like 40, 1 in 80, 1 in 160. Once the titer, you detect it in like 1 in 100, 640. This is really very, very, very specific. If you detect it really high titer. So how to treat lupus? Remember, the treatment, it depends on the organ affected. If the patient has mainly joint pain, I will give the patient paracetamol, non-steroidal, hydroxychloroquine. If the patient has a kidney involvement, the patient will need stronger treatments like cyclophosphamide, cyclosporine, azathioprine. The patient has CNS, the same, cardiac. It depends on the organ, and it's not internist decision. It's a rheumatologist and collaboration with nephrologist, for example. So patient with mild lupus, like skin joint, hydroxychloroquine to use for like malaria, okay, or chloroquine can be used with short-term steroid. The patient has severe joint pain, you can give short-term steroid and stop it. But make sure that you tell the patient side effect of the corticosteroids. We give the patient calcium, we give the patient vitamin D. Any side effect of hydroxychloroquine? Thank you. Thank you. Long-term treatment with hydroxychloroquine, the patient has to be seen by a pharmacist. Excellent. Let's do that. Second one, patient with moderate lupus involvement, moderate, but non-organ like affecting disease, you can give still hydroxychloroquine plus the steroid. Steroid sparing immunosuppression like Imuran, methotrexate, required to control the symptoms. Why wouldn't depend on the steroid? Systemic side effect. Okay, tolerance. And again, it doesn't really work on long term. The patient will be dependent on it and difficult to stop it, and it has a lot of side effects. What about if the patient has lupus cerebritis, or lupus pneumonitis, or lupus pancreatitis, or hepatitis, or nephritis? You need the big guns, okay? It depends on the organ involved. You have to make a correct diagnosis. Then the patient will be given really strong treatment, like cyclophosphamide, okay? You can use rituximab, mycophenolate mofetil, which is the Celsat, another immunosuppressant. This treatment has to be given and assess the response clinically and biochemically. For example, the patient has lupus nephritis. How you assess? Again, the proteinuria will be better, kidney function will be better, If the patient has lupus cerebritis, seizures will be less, psychosis will be better. Any questions about SLE? Clear? Can we switch gears now to another connective tissue disease, which is
Systemic
systemic sclerosis. Systemic sclerosis, okay? Remember this image. This is typical. This is typical. You think this one or this one? This one, okay. Remember this face. Just keep it in your mind. Systemic sclerosis or scleroderma. So the skin is getting fibrotic, tight, and tense. Okay? And not only the skin, what you can see here, I don't know if it's very clear for you or not, but maybe from distance you can see what are these things.
Aging.
No, actually these are blood vessels dilated, like telangiectasias. I think they're clear from here. I can see that. Telangiectasia, dilated blood vessels. Okay? So again, tight skin, like fish mouth appearance. Okay? And you see the wrinkles. And they can't even open the mouth. Sometimes you can ask the patient to open the mouth and you can just try to squeeze 2 or 3 fingers with difficulty. They can't open it. Very tight skin. This is what we call systemic sclerosis. So it's chronic, again, multi-system disease, vascular dysfunction, and progressive fibrosis of skin and internal organs. Internal organs. So the hallmark feature of this is used to describe the presence of thickened, hard skin is the scleroderma. Okay? But the correct name is actually systemic sclerosis because it can affect deeper organs. Okay? Unfortunately, I don't know, of course it is more in females, but now we are giving discount instead of 10 to 1, 5 to 1. Okay? And the peak incidence is between 30 to 50, and men tend to have diffuse disease, and women will have limited disease, and we'll discuss that later. So what do we mean by this? Limited or diffuse. So for limited, you have what you call CRIST syndrome. So CRIST stands for calcinosis, renodes, esophageal dysmotility, so they get some sort of heartburn and reflux. Sclerodactyly, with the tight fingers, sclerodactyly, sclerosis of the fingers, telangiectasias, and pulmonary hypertension without lung fibrosis. Keep this in mind. So it is limited. Let's go to the diffuse part. CRIST syndrome with viscera. So you find the CNS, the cardiovascular, lung and kidney. And the kidney, they have a syndrome they call scleroderma crisis. They get severe hypertension with proteinuria, it's sometimes life-threatening, like medical emergency for those patients. Keep this table in your mind. We have limited and we have diffuse. Now, features like lupus, multi-organs. You can see what you call salt and pepper appearance. Calcinosis, you can see this as calcium in the fingers. Okay, can you see in the X-ray the calcium deposition? Telangiectasia, like our patients, this is exactly blood vessels. You need to have like magnifying glass to look at these blood vessels dilated. Sclerodactyly. And again, the blood vessels will be affected, so it might lead to ulcerations and necrosis. You can see the skin is very tight, okay? Microstomia with short renal. So you see the mouth itself is very tight and rounded, and mask-like faces. We talked about renodes already in lupus. It's the same. Okay, renodes can be primary without any secondary causes, or can be secondary related to lupus or other connective tissue diseases. Extracutaneous. We talked about the kidney, renal crisis. We talked about esophageal with reflux. The heart fibrosis, myocarditis, pericarditis. Joints, of course, can be affected because this is always rheumatology. You are always in your hand is the knee and the joint and the wrist can be affected. And the pulmonary, which is one of the most leading cause of death with the kidney in patients with diffuse type. But remember the pulmonary hypertension and limited type. How you diagnose this thing? Again, the patient will not come to you and say, doctor, I have tight skin, I have sclerodactyly, I have telangiectasia, but I have no. They come to you with symptoms. They come to you with joint pain, they can manifestation like of telangiectasia, with heartburn. It depends on the organ affected. Okay? So you need to do the basal workup like CBC, renal, hepatic, urine analysis. But we need a serology now. We need to be directed to plaque lupus. We looked at 3 antibodies. For scleroderma, you look for anti-centromere for limited, and for the diffuse anti-scleroderma 70 or topoisomerase antibody. Okay? So remember these 2 antibodies for 2 different classes of scleroderma. So for the limited, centromere. For diffuse is the topoisomerase. You can look at chest X-ray for pulmonary involvement. You can do pH monitoring for reflux. You can do echo for a patient with signs of pulmonary hypertension. You can do skin biopsy to diagnose fibrosis. And you can even diagnose any organ based on biopsy or functionality of that organ. How to treat scleroderma? It's like lupus. Go ahead.
The patient can't feel that their skin is tight.
They feel it.
So they will tell you if their skin is
Yeah, but they think it is normal. Unless they read about it, or when they take the well, what's your skin like this? They might not recognize it. But really, if you see a typical patient, you assume the patient should recognize this. But they don't present late stage. Usually they present early before this happens. Can you stop this? Unfortunately, there's no treatment to stop this from fibrosis. Right, so treat the organ that's affected. So physiotherapy, prevent dry skin, and for example, lung disease, you give cyclosamide. GI, reflux, you give proton pump inhibitors. Pulmonary hypertension, there's a treatment, there's like a wide spectrum of treatment to reduce the pulmonary artery hypertension. Raynaud's, remember the Raynaud's? The patients who turn from pale to blue to red. They usually avoid cold, avoid smoking, and they can use, like, especially in the winter, they put gloves. Renal crisis, it's better to give these patients asymptomatic. Skin involvement, we can consider methotrexate, and for musculoskeletal, we treat with methotrexate and analgesia, and you can use hydroxychloroquine. Now we talked about lupus. By itself, lupus is a lecture, not a lecture. Even lupus nephritis by itself is a lecture. But we now covered lupus principles and concepts about it. Now we know about scleroderma. What about mixed connective tissue disease? This is very rare. Just keep it in mind, one of the rare diseases in rheumatology. You need to have some sort of antibody, which is the anti or RMB, the RMB antibody. This is really specific to this disease. So what you need to have is this antibody with constellation of signs and symptoms from other organs. So patient will have fatigability, will have myalgia, arthralgia, Raynaud's phenomenons, and any organ can be affected. The skin, the muscle, the heart, like others. Okay? But the antibody, that one is really, once you detect it, think about it. The treatment will be more or less the same. It depends on the organ affected. Like lupus, like scleroderma. Again, here one slide to summarize everything about mixed connective tissue disease, the manifestation itself, the organ involvement, the lab that you find, and the first one is the RMB that you have to keep in mind, and the imaging. The lung, you might find fibrosis, chronic glass appearance, You might find pulmonary infiltrate, fusion, and even for the cardiac, you may find myometrics. You might find myocarditis. Okay, pericarditis can affect even the heart. There is actually criteria to diagnose, but don't really be anxious or worried about this criteria. I gave you what did we give before? We gave the slick and for the saline. There's criteria for scleroderma and now there's criteria for mixed phenotypic tissue disease. I found actually the second one, which is the CAN criteria, used more. Okay, so they need serology and need also clinical features. Okay. How to manage? It's more or less the same like lupus, like depends on the organ involved, okay, and severity of the disease. Again, keep in mind number 3, it depends on the organ involved. But again, any treatment you give, including steroid, think about the side effects. Non-steroidal, think about gastric ulcer. Even the patient might have a reflux. The patient has scleroderma, and you give NSAIDs, the patient might get worse, so always give proton pump inhibitor. طيب who does take the first question? B? Correct.
Yes.
Excellent. Second one?
D.
Oh, you are awake. Thank you. That's good. Okay, D. طيب, who would like to read this one for me? You. Go ahead.
40-year-old woman comes to the clinic for a 2-month history of chest pain and heartburn after meals. The patient reports that the pain is worse at night, and especially when she's lying down. She has history of Raynaud disease, treated with nifedipine. There is no family history of serious illness. She immigrated to the US from Nigeria 5 years ago. She does not smoke or drink alcohol. The vital signs are within normal limits. Cardiopulmonary examination shows no abnormalities. Thickening and hardening of the skin is seen on the hands and face. There are several firm white nodules on the elbows and finger.
What are these whitish nodules?
Calcification.
Carcinosis. Excellent. Okay.
Further evaluation of this patient is most likely to show which of the following findings.
What's your diagnosis? Which one? The limited or the
Limited.
or diffuse? Limited. What's the antibody? D. Anticentromere antibody? Can I take the second question?
A 43-year-old woman comes to the physician because of a 2-month history of chest pain. She describes the pain as intermittent and burning light. She states that she has tried using proton pump inhibitors but has had no relief of her symptoms. She has a 5 kg weight loss over the past 2 months. Her temperature is 36.7, pulse is 75, blood pressure is 150/80. Examination showed tightness of the skin of the fingers. There are small, non-healing, non-purulent ulcers over thickened skin on the fingertips. Fine inspiratory crackles are heard on both lung bases. There is a mild tenderness palpation of the epigastrium. Which of the following is most likely associated with her diagnosis?
Is it B? B.
Okay, so the first one was, first case was? Limited. This one? Diffuse. So you choose which one?
B.
Okay, so that one was D and this is B. I think this is the correct answer. And the slides with you, you can go to the table to differentiate and to carry over. Like, who would like to take the first one? But can I detect you at the back with your mobile? Go ahead, read it.
Which of the following is nearly twice as common in patients with diffuse cutaneous systemic
Sclerosis.
sclerosis that
than in limited. So now this is a tricky question. Which one more in diffuse? Than limited. I stressed on that in the slide.
B or C? C.
Huh?
C.
See? So now we are talking about diffuse. Diffuse. Fibrosis in diffuse, correct?
Yes.
Exactly. So the correct answer is C. Okay, now we will take